Good morning from Belfast. We are pleased to introduce you to day 3 of the Let's Talk Clots conference that has been organised by UK Thrombosis UK, really to celebrate the birthday of Rudolf Virchow that was yesterday. So this morning we have 2 of the pharmacists from Belfast Trust, Brian Proctor, anticoagulant specialist pharmacist, and Sharon O'Donnell, the medicines governance pharmacist, to tell us about their project that was started in 2019, long before they'd heard of COVID-19, but actually proved very valuable when COVID arrived in March. So Brian and Sharon, I'd be pleased if you would tell us about IT in the new era of managing patients on warfarin.
Thank you very much, Dr. Boyd. And thank you very much for the opportunity to present our experience of virtual INR clinics in the management of warfarin. Our INR clinic serves the Belfast area and provides support to Belfast Trust hospitals and GPs in primary care. The clinic mainly uses point of care testing, and the patients that attend are seen, tested, and dosed all in the one visit. Yes. During the COVID pandemic, our clinic faced a common problem of how to manage patients who have been advised to shield and how best to tackle reducing visits to clinics and to reduce footfall in the hospital site. Like many clinics, we followed the British Society of Haematology's guidelines, which were released in March for outpatient INR clinics. Where we could, we switched to DOACs where we could, except for those where it's not appropriate, such as those indications highlighted, such as mechanical heart valves, those with antiphospholipid syndrome, triple positive, those with renal failure, those with non-standard or higher INR ranges, and those where DOACs can't be used due to interactions, although that list is not exhaustive. As Dr. Boyd mentioned, we started a quality improvement project at the end of last year to develop our INR self-testing at home. And we ramped this project up during the pandemic with the constraints such as the temporary reduction of availability of home INR meters due to the high demand seen during the pandemic. Just to differentiate between patient self-testing and patient self-management, patient self-testing refers to where patients test their INR at home on a home INR meter, and that INR result is communicated to the healthcare professional who interprets the results and advises on dosing. Patient self-management is where the patient tests their INR at home, interprets the result, and after some training, they make their own dosing decisions, usually following an algorithm or a table, but it involves further training. Both have been around for a long time, and there is evidence that this approach can improve anticoagulant control in selected motivated patients. There have been 2 Cochrane reviews, and it's been advocated in both British and US guidelines, again, for use in suitable patients. In 2014, NICE produced guidance recommending self-testing in adults and children on long-term warfarin with the criteria that the person prefers this form of testing and that the patient or their carer is both physically and cognitively able to self-monitor effectively. I will now hand over to my colleague Sharon to continue.
Thanks, Brian. Yes, so as Brian has said, then we were approaching this as part of a quality improvement piece of work. We knew there was sound evidence, as Brian has outlined, for INR home self-testing, and we already had one patient established on a home self-testing model. So our question now really was, could we safely expand this? And we thought the quality improvement methodology would help us with this. I should say, and as Dr. Boyd had said, I'm the medicines governance pharmacist in the trust. I don't work at the clinic, but I have an interest in QI and was undertaking the Scottish Improvement Leadership Programme. I'd started that about this time last year. So I thought I could support Brian and particularly Dolores, the nurse in the anticoagulant clinic, in this piece of work. The SKILL, or Scottish Improvement Leadership Programme, very much like other quality improvement approaches, uses the model for improvement, and particularly the Plan, Do, Study, Act, PDSA cycles, which I'm sure people are familiar with. Could I have the next slide, Brian, please? Oh, yeah, that one. Yeah. So this was our project aim when we set out at the end of 2019. We wanted to increase the number of patients on warfarin who were looked after by Belfast City Hospital Anticoagulant Clinic. So we wanted to increase the number of those patients who self-test their INR at home from 1 to 5 by the end of May 2020. Now, this may seem like quite a modest aim. Again, those of you familiar with quality improvement will know that one of the mantras in quality improvement is, if you think your piece of work or your project is small, make it smaller. So as I said before, what we really wanted to make sure is try out different approaches so that we knew we had an approach that would work, and then we could scale and spread. The next slide, Brian, please. So as I mentioned, we were using the Plan, Do, Study, Act cycle approach, and I thought it might be interesting to talk through some of those we did, particularly as it's relevant to, I guess, the sort of the technology side of things. So we were running a virtual clinic. The idea was that we would have video calls with the patients. So again, as I say, this Plan, Do, Study, Act approach, we wanted just to test that out to see if our technology would work as we expected it to. So Brian works on one site in Belfast Trust, I work on another. So we thought, well, we can test this out very easily. Brian will send me the link to Skype. I'll click on it and we should be able to start our video call. And that way we'll know this will work when we move to our first patient. So we tried that out, but it didn't work. The link on my mobile, when I opened it, the sound was really poor. It was in and out. We had very poor picture as well. So then we decided, well, we'll try using the Skype app, which I didn't have at that stage on my phone. Tried that. That was a little bit better, but it still wasn't good enough to run a virtual clinic, we felt, safely. So then Brian, who's quite a technophile, had to think about this, and he came up with, well, if I tried doing this but had the Trust Wi-Fi or was connected to Trust Wi-Fi, would that make a difference? So we tried that out and we found that worked perfectly. We had good picture, good sound, and again, as I say, this was all about making sure this could be done safely. So we felt we now had a good, if you like, safe platform for starting our first patient off. We did at a time later move to Microsoft Teams, and again, Brian will talk about that a little bit later. The Trust made that available, I think, around sort of February, March, and that's quite a very useful platform as well for these virtual clinics. The next slide then, Brian. So in terms of some of the things we did, obviously we needed to recruit some patients. So again, we had some interesting PDSA cycles around recruitment. You can see this is one of our posters that we tried out. What we found, and I guess it's probably common sense really, is that patients were more likely to be expressing interest in the project if Brian or Dolores mentioned it to them, and people they knew and trusted, rather than just sort of responding, if you like, to a poster on a wall. We had to do some sort of iterative PDSA cycles around sort of what we would, what we were developing for patient and staff training. And I think an interesting aspect to all of this is we had a contract between the patient and clinic. So I think that was a really good thing, because it meant the patient knew what was expected of them in this virtual clinic sort of approach, and also what they could expect from the clinic as well. And we did some baseline and follow-up patient surveys as well. Move the next slide then, Brian. So just to give you an idea of our progress to date, so the chart you're looking at shows you the number of patients testing now their INRs at home through Belfast City Hospital Anticoagulant Clinic. On the horizontal axis, you've got the week since we started the project, which was right at the end of November 19. Vertical axis is the number of patients, and each data point is the number of patients who are home self-testing in that week. So you can see we had something of a slow start. We had some difficulty getting hold of meters. They're about £300 each. Obviously, we're dealing with a high-risk drug in warfarin, so we needed to make sure our standard operating procedures were absolutely watertight. So that took a little bit of time getting those developed, getting those approved. And we also found that while patients were interested in this idea, some patients were more than happy to continue with the model of care where they attended the clinic and so on. So there were, I suppose, a handful of patients certainly at the start who were interested in the concept of INR home self-testing. We had our first patient agreed, I think it was towards the end of January, that he would self-test. I think his story is quite interesting, and he isn't one of the patients we see in the testimonials later, but I think he's an interesting, or his case is interesting in that it shows the benefits to, or the improvements to quality of life by this approach. So he's a patient on lifelong warfarin. He's a secondary school teacher with a young family, a busy life. So he was really struggling to get to his appointments. Although resident in Belfast, he worked about 20 miles away. So was then missing appointments, and that was having a knock-on effect on his anticoagulation control. So when he attended for training and was able to start using the virtual clinic, we found that instead of having to take, say, 3 hours out of work, whether that be weekly, fortnightly, monthly, depending on how well controlled he was, drive into Belfast, park at a busy hospital site, and then come in for his appointment. So he went to, if you like, from 3 hours per appointment to 10 to 15 minutes per appointment. So you can see that alone is going to have a beneficial impact on quality of life. You can also see from our chart that we met our target of 5 patients home INR self-testing around the middle of March or so. So we're pleased with that. But you can also see from the chart something else is happening, and that something else is, of course, COVID. So around sort of end of March, Brian and Dolores were getting calls from their patients, now more interested in, if you like, the INR home self-testing. Patients who previously, were happy to come into hospital for the clinic and now weren't so much if they could help that. So we also had our trust. We're asking the different services, how are they going to continue to deliver that service during COVID? So that gave us an opportunity to get funding for some more meters. So you can see our numbers increased steadily then over sort of April and May. We had a bit of a ceiling because that was the number of meters we had. And then interestingly, at the sort of far side of the chart, you can see we've had a slight increase towards the end of August in our numbers, in that one of the other services in the trust, the congenital cardiac service, became aware of the project, and they were keen for their 3 patients who attend the clinic to move to INR home self-testing. So they purchased some meters for us. So, and I suppose the other thing I should say, since I put this graph together, I think we're at about 21 patients now. So there's a little bit of updating perhaps to do to that graph. So if I hand you back now to Brian, who talked through some more of the results and basically how the clinic runs.
That's great. Thank you very much, Sharon. So this graph shows the clinic attendances per week from the 2nd of February. With our COVID measures, weekly attendances reduced, as can be seen. Also, our number of referrals reduced as well, as less referrals were coming to our service from secondary and primary care. This is the same graph, this time adding in the virtual INR clinics and also those patients who require community INR samples with the help of district nursing. As we see, the attendance was reduced. District nursing requests remained the same, if not slightly increased over time, and we were seeing more patients virtually. Currently, for the last few months, we're having most reviews done virtually. We didn't expect to get much information regarding INR control, but we have some for some patients. So in our patients, we did see a reduced incidence of INRs greater than 5. There wasn't any difference in the incidence of low INRs less than 1.5. Again, we really can't read too much into this because the numbers are very small, and maybe other factors, patients staying at home, focusing on their health. So really not enough data, but the incidence of high INRs was reduced. And also the incidence, actually the time in therapeutic range for many patients, we did see an improvement. Again, the numbers are very small. Those dots to the right of the red dash line are an improvement in INR therapy, the time in therapeutic range percentage improvement. Again, the numbers are very small, but it is encouraging to see that our small results are consistent with the existing evidence. The project focus was more on the positive patient experience for those patients on long-term warfarin. Our satisfaction survey was good. We didn't receive any negative feedback from patients. The rating 9.2 to 10. And there's some of the selected quotes, most often relating to saving time, reducing travel. I think it's a really good service. To show some of the patients' experience in the pilot, we have put together a short montage of patient testimonials, which I'll play now.
Brian, I don't think we can hear the speech I don't think we can hear what the lady's saying.
Brian, can you adjust the sound? We can't hear.
Cheers.
No, it's absolutely silent. No, similarly, absolutely silent.
Silent, is it?
I wonder if it's something to do with the fact you're using the headphones, Brian, with that? Because the sound's not brilliant with the headphones, I have to say. Maybe that's just me.
There's a lot of whistling from the headphones or the microphone.
Is that any better?
Yeah. We can hear, well, I can
We can
hear.
hear. Not really.
No. I'll stop it.
No, we can't hear, Brian.
Okay, apologies. Okay. Okay. Apologies. I believe we're having some problems with the sound, so I'll skip past the testimonials. For the project, we initially started out using Skype for Business, but we moved to Microsoft Teams as the hospital trust was starting to use this and promote this platform, although Skype did work very well. In terms of technology, Microsoft Teams comes with a booking application, which provides very simple and friendly user interface for patients and staff to manage their bookings, and integrates well with our clinic's shared calendar. The Trust are moving to integrate Microsoft Teams booking with our own appointment booking system for the various virtual clinics that are taking place. In practice, we aim to have Microsoft Teams installed on the patient's device and working before they attended for meter training. We asked that the patient was seen face-to-face, just so that we can see the result on the meter and converse with the patient, and to ensure things like they're completing their yellow record book. We appreciate there is, with the newer anticoagulant devices, Bluetooth capability, which can transmit INR results, but it's not something because we are starting out quite small, it's not something we looked into or adopted. We relay dosing advice in the meetings notes function of the Teams, so the patient gets a copy of their dosing advice sent to them. And as per the British Hematology Society guidelines, we ask the patient to attend clinic every 6 months with their yellow book to run quality control and just to have a review. Online presentation materials can be produced very easily with Microsoft Teams, which look good on different types of mobile device. Most of our patients were using a variety of devices, their home laptops, computers, or some on mobile. And we were able to produce nice pages such as frequently asked questions on the INR self-testing process, and also frequently asked questions on warfarin in general, as well as our feedback surveys. There's also a good opportunity to link patient support, such as this very Thrombosis UK virtual conference and the previous ones in May 2020, which are all sort of very good patient support materials, particularly around the pandemic. So our findings of the pilot so far is that the appointments themselves have been generally shorter by video call and a bit more down to business. There's a higher amount of email correspondence we found between patients and the service. We didn't previously ask for email addresses, and it seems to be more emails being sent to us in the clinic, which has good pros and cons in terms of patient engagement with the service, but there might be problems with rules of engagement issues and the workload of emails. Non-attendance numbers were low in our pilot, although the patients were all initially motivated. from results so far, it's probably a positive impact on INR stability, and there is a positive impact on the patient satisfaction just from our satisfaction survey. We'd see this as a bridge for some patients to go to self-management of warfarin, where they would take more control of dosing themselves and get that further training. So probably acts as a bridge towards that. And also on the IT side of things, to reduce the visits to hospital, and we find applications such as digital contract software are useful. So things like our patient clinic agreement could be signed remotely. In terms of the video consultations, we found it would work better if we already had some patients we already knew. We wouldn't use this as our first visit with a patient. We would probably wait a while until we set up the virtual clinic. The future of the project is we're looking to expand it and see where it fits in our current model here in Northern Ireland, and also looking to maybe adapt in our community care facilities as well. At the very start of the project, we asked the question, is our INR clinics a good fit for video consultations? And this diagram from Professor Trish Greena at University of Oxford provides a good decision tool in this respect. We would probably say yes for motivated patients for the various points shown. We're monitoring a stable condition. Physical examinations usually unnecessary, and it's probably unlikely to be a complex or challenging consultation. So it probably would be suited to a webcam consultation. For virtual clinic information for patients and staff, we find these resources very useful that we give to our patients. Again, from the University of Oxford and Bart's Hospital, they produce really excellent pictorial guides on the process and YouTube videos as well. So the reference is there, which is what we've been using in our clinic. And again, this is the last slide, and just some of the useful resources we've seen and been using just for our clinic. And I'll stop there, and we'll be happy to take any questions. Thank you very much.
Brian and Sharon, thank you very much. That was very interesting. I'm sorry your patient testimonials might work for us, but it was very good with the patients, and thanks to them for participating. I haven't seen any questions just yet on the question and answer box, but can I ask you, in terms of moving forward, have any of the patients volunteered to buy monitors, or do you think that the onus is going to remain on the health service to try and provide these? I think for a lot of the self-management programs, patients would actually invest, and have any of your patients shown any willingness or intention to do that?
Yes, yes, there was availability problems with the meters for a period, and again, they are quite expensive, and there isn't the funding in place in Northern Ireland for the meters. So yes, we had patients who had bought meters and enrolled in the project, and we thought that was fine, because it was working, and there's quite later on in the project, and things were working well at that stage, so we didn't see any objections.
Very good.
It was just to make it equitable. It was whenever we first advertised the project, it was first come, first served.
First served.
We were quite equitable in how we give out the meters.
And have any of them taken the next step or asked you about actually self-management?
Yes, we will look to push patients on to self-management, we think. And I think it's worked well. It's given them a taste of what's involved, really. And it will, I would say, don't see any problem for them taking the next step to get the training and go to self-management. I think we give this option probably because of the pandemic as well, in fairness. The option was there.
No, it was very, very timely, your introduction. In terms of your time in the clinic, do you think now that it's up and running, is it going to make the clinic more efficient for you? Or do you find that you're just spending just as much time per patient, or do the emails, will you tell us a bit about the emails? Are they questions in between visits, as it were?
Yes. So I think it's just another channel of communications for patients, which is fine. You know, we have a shared email box, so anybody can answer the question once it's picked up. And you know, we do encourage that engagement with patients regarding procedures, medication changes, and general advice, which we would ask at each appointment anyway. So we would. It's good that they're engaged with their treatments, and we would encourage that. The terms of our clinic workload and how these appointments are managed, we do find we do ask the patient to be on time with their appointments, and the appointments are stacked one after the other. So it is quite efficient in that respect, and that when they were attending, they might not attended. Two patients might attend at the same time. One was late and one was early, for example. So it does avoid the clashes, the patients double booking, where everything's quite organized in the calendar for booking. So it does probably improve efficiency from that point of view, and that our clinic doesn't get too many patients at the one time.
Yes, and for social distancing. We have one question here. Most of the patients at this clinic are elderly, and how are they coping with virtual clinics? Have you many elderly patients participating?
We do, and we have a few, and again, we find it's really family members who are helping out, children, grandchildren who are doing the tests for the parents and conversing with us through the video calls.
Yeah.
And the guidelines are saying patients are their carers. So yeah, so we do have some elderly patients who that responsibility has been sort of taken on by the family members, and it's working well. So from that point of view.
And is that how you see it being rolled into residential care? You mentioned that as a future possibility. Would you imagine that the nurse or the manager of the residence actually taking responsibility, doing the tests on her client?
Yes. Well, we're in conversations. We have a few in care facilities. At the minute, they're all district nursing requests. So potentially, again, it's down to who's going to do the test and who's going to speak to us. But we are in conversation with some care facilities to see if that is a role they would be prepared to take on. I don't think the IT, the connection with through the video calls is going to be a problem. But I think it'll be more who's doing the tests essentially. But so we're in conversations with some of our patients in the care facilities.
And maybe just to add to that, Brian and Kathryn, just that certainly I know I've had colleagues who work in the nursing home sector say to me, you know, anything particularly now in COVID that they can do to reduce footfall into the home, you know, I think they'll even be more likely maybe to want to take this on than perhaps pre-COVID. So I don't know if that, Brian, that may be something then we are trying to scale and spread.
Thank you. And from your perspective, Sharon, your quality improvement project, obviously is something that you think is sustainable and you've achieved change, you've improved patients' quality of life. Your aim, essentially, is that right?
I didn't hear the very last bit.
Quality of life, yeah.
Quality of life, yes, no, absolutely. And we kind of knew at the start that, you know, the patients were very well controlled, the patients who Brian and Dolores were looking after. So we almost didn't expect to see very much in terms of that. But as I'm sure people are familiar with, a quality improvement approach is very much about measuring that your change is making a difference. So we are seeing that in terms of the quality of life, the time taken, and in some of the sort of the clinical parameters. But I do think, I mean, I guess I'm quite converted to the whole quality improvement approach now. You know, I think it's a really good way to sort of show that the change you've made is an improvement. And I think while you might say, well, you know, it was going to change with COVID anyway, I think, you know, Brian and I and the rest of the team, obviously yourself, Dr. Boyd, Charlene, Dolores, you know, we laid really sound foundations with our sort of
Yes.
our iterative approach, our plan, do, study, act. We knew the things that were going to work, so we were in a position to scale it up when we got the opportunity to do so. And I think that very much kind of rests. We had the Quality Improvement Foundation helped us to do that.
Thank you very much. It's now just 10 o'clock, so perhaps we should end the conference there. Thank you both very much. Was it very interesting, and best wishes for future IT projects. Thank you.